So an overview of what we're going to talk about today is an overview of GU cancers and what they entail. We'll talk a bit about the epidemiology of these cancers, how they're staged, the overview of the current treatments, and then the main focus of the talk is going to be about current clinical trials that we have on offer here at Barts and ongoing research in the respective fields. And as I mentioned, we'll take your questions at the end, but feel free to interrupt me if you have any burning questions. So when we talk about genitourinary oncology, we treat three types of cancers. So when we talk about genitourinary oncology, we're talking about cancer of the kidneys, the ureters, which is what we call upper tract cancers, and of the bladder and urethra. These aren't the most common cancer in the UK. We hear a lot in the press about breast, lung cancer, bowel cancer. Kidney cancer is slightly more common than bladder cancer. It's the 7th most common cancer, and bladder, I think, is about the 13th. So when we look at treating cancers, that we use a modality of treatment options, and often for one particular cancer type, we use a range of these different treatments. So we might use a combination of therapies such as surgery, chemotherapy, targeted therapy, and immunotherapies. And you'll notice that when I talk about some of the current research, a lot of this is focused on combinations of therapies and maximizing targeting the cancer from lots of different angles. We'll start with bladder cancer. So bladder cancer has about 10,000 new cases per year in the UK, but has still quite a poor survival, with only around 46% survival for 10 or more years in England. The causes of bladder cancer are largely unknown, but there are certain risk factors that can increase your likelihood of getting a bladder cancer during your life. One of them is chemical exposures at work, particularly to things like dyes or people in the textile or manufacturing.
I'm just joining up the camera.
Is everyone okay?
Yeah.
Perfect. So chemical exposures, people in the manufacturing industry. Chronic bladder inflammation, this can be from recurrent infections because the inflammation can cause damage and to the bladder lining. Lifestyle factors, particularly smoking, the risk of getting a bladder cancer is many more times increased for a smoker compared to a non-smoker. Certain medications, particularly those for type 2 diabetes, although this is a fairly new area of research. There's certain genetics, so if someone in your family has had a bladder cancer, then you're more likely to get one. And arsenic in water, although that's less important in Western countries, but still an issue in developing countries. So the symptoms of bladder cancer can vary between patient to patient. Some common symptoms include blood in the urine. This is the one that usually makes patients panic and go to their doctor. They might also have blocked urine flow, or indeed symptoms of a urinary tract infection, things like pain or irritation on urination, or having the constant urge to urinate. And if you think about that, it makes sense, because if you have a bladder tumour growing on the lining of your bladder, it's going to irritate the lining of the bladder in the same way an infection might, and cause some uncomfortable symptoms. If the bladder cancer becomes more advanced, you can get some more systemic symptoms such as fatigue and tiredness, which can also be caused by anemia from the blood loss, loss of appetite, and also abdominal pain. The stages of bladder cancer can be quite complicated, and we don't need to go into detail of this, but it's important to have a clear stage at the point of diagnosis, because the treatments are often guided by what stage the cancer is. So if you have a look at the diagram on the left, this is a diagram of the layers of the bladder wall. You can see that the early stage tumours, so the cancer in situ, CIS, PTA, PT1, are confined to the inner layers of the bladder. And as we progress through the stages 2, 3, and 4, it becomes deeper invasion into the bladder wall. At T4, this means the cancer's advanced and it can spread out of the bladder to other organs or through the blood and lymph tissue to other sites in the body. And bladder cancer commonly spreads to lymph nodes, lung, liver, bone, and sometimes brain. Some patients, and particularly that we see in our clinic, often present at quite late stages when the cancer has spread to other sites of their body. When we talk about bladder cancer, and you might have heard the terms non-muscle invasive or muscle invasive bladder cancer, and this relates to how deep the bladder cancer has invaded into the bladder wall. And this is really important for therapy because when we talk about a non-muscle invasive cancer, then the treatment options are potentially curative, meaning we can eradicate the cancer. Whereas when the cancer has invaded into the muscle, the treatment becomes a bit more complicated and may involve surgery or systemic therapies. So as I mentioned, we split the treatments depending on whether it's non-muscle invasive, muscle invasive, or indeed metastatic, meaning it's spread beyond the bladder. For non-muscle invasive bladder cancer, the treatment is quite localized. We can look into the bladder with a TURBT, which stands for a transurethral resection of the bladder tumour. And I have a diagram of what this involves on the next slide. And then intravesical therapy, which means pretty much administering cancer therapies directly into the bladder using a catheter. For muscle invasive bladder cancer, the treatment options usually involve surgical removal of the entire bladder, which is called a cystectomy. And for metastatic, it involves systemic therapy, meaning giving treatment into the vein or via a tablet so that it can absorb into the blood and target cancer all over the body. This diagram on the left is what a TURBT looks like. So you can see that there is a cystoscope there, which has been inserted through the urethra into the bladder, and we can cauterize and remove the bladder tumour from the superficial layers of the bladder wall. This is for non-muscle invasive bladder cancer only. And after doing this procedure, the patient would likely then have a course of BCG therapy, which is basically injected via a catheter directly into the bladder, and it will cause localized inflammation of the bladder lining and hopefully kill any remaining cancer cells. For muscle invasive cancer, the treatment options usually involve surgical resection. You can see in this image one of our clinical fellows, Bernadette, doing an operation here. And sometimes before and after surgery, we give some systemic therapies, either before surgery, which is what we call neoadjuvant treatment, or after surgery, meaning adjuvant treatment. And this can be to shrink the tumour down before surgery to make the surgery more easy, or to mop up any potential cancer cells that could have remained in the body after the operation. For metastatic bladder cancer, that means when the cancer's spread beyond the bladder where it started, the treatment options are called systemic treatment, and this usually involves giving chemotherapy or other therapies through a drip into the vein so it can target cancer wherever it may be in the body. I won't go too much into detail about the requirements for chemotherapy, but usually first line we give chemotherapy or clinical trial options. Some really interesting trials are ongoing at Barts in the setting of urothelial cancer. The urothelial cancer is an umbrella term for cancers of the ureter, which is the tube from the kidney to the bladder, or the bladder itself. If we go through some non-metastatic trials, we have one called Abacus 2. Now, this is an exciting new trial which is trying immune therapy before surgery. So these are patients that are going for a cystectomy or a nephrouretectomy, which is removal of the kidney and the ureter, for urothelial cancer. Usually, we would give some chemotherapy before the surgery to make the surgery easier. But in this setting, we're giving 2 cycles of atezolizumab, which is just a fancy name for some immune therapy. We've established this trial here at Barts, and we're involving other sites in the UK and Spain with an expected number of patients of 58. Volga is a trial that we have opened in the last few weeks here at Barts. This is again a perioperative trial. This is trying different treatments, immune therapy, so durvalumab and tremelimumab, although the names aren't so important for this talk, plus an antibody drug conjugate called enfortumab vedotin, or on this diagram EV. An antibody drug conjugate is basically a chemotherapy agent, but with a more targeted molecule to go and target the cancer. In this trial, some patients will go straight to surgery, or some patients will have different combinations of therapies before and after the cystectomy to remove the bladder. In both of these cases, the trials are for potentially curative patients who are going to have their bladder removed. We expect to have 830 patients involved in this study worldwide, and I believe that we have recruited our first patient in the last couple of weeks. A really exciting area of research in bladder cancer or urothelial cancer is that of ctDNA. ctDNA stands for circulating tumour DNA. Usually, when a patient has had their surgery, as you can see in this diagram, they're followed up with CT scans and imaging every 12 weeks. ctDNA is an exciting new concept which potentially picks up residual disease or tumour recurrence earlier than it would show on a CT scan. So we would do a blood test at periods after the surgery and see whether there was any evidence of cancer DNA in the patient's blood. When we think about a CT scan, 1 millimetre of cancer on a CT scan represents thousands and thousands of cancer cells. So ctDNA is a much more refined way of picking up early recurrence after surgery. There's also other ways that we could use ctDNA, such as monitoring response to treatment. If you look at this graph on the right hand of the slide, you can see where we've given adjuvant therapy. You can see that as we give therapy with time, the levels of ctDNA in the blood reduce. This could predict response of a patient to the therapy. And I think that in the future, we'll use this a lot more, and scans will become more of an additional way of monitoring patients rather than the only way. InVigor 011 uses this concept of ctDNA. These are for patients who have had a cystectomy for urothelial cancer or muscle invasive bladder cancer. After they've had their surgery, they would usually be offered CT scans every 12 weeks. But if they enroll in this trial, they will also have a blood test every 6 weeks. We'll test them for circulating tumour DNA, so that is markers of cancer in their blood, every 6 weeks. And if they become positive for remains of cancer and it shows us that the cancer's potentially come back, or indeed residual after the surgery, then the patients will be randomised to either receive some immune therapy called atezolizumab or a placebo treatment, so a dummy treatment. And we'll look to see whether, first of all, testing for the ctDNA helps patients, but also whether giving those patients the immune therapy improves their outcomes. When we look at trials in the metastatic bladder cancer setting, we have a really interesting new trial called DISCUS, which is comparing 3 versus 6 cycles of chemotherapy. Usually for these patients, we'd give 6 cycles of chemotherapy, which is quite a large dose for patients. But actually, when you look at the literature, the rationale for giving 6 cycles is quite historic. And actually, many patients find cycles 4, 5, and 6 quite tough in terms of side effects, admission to hospital, and their quality of life may reduce during this time. We know that patients usually become resistant to chemotherapy, and many patients progress between cycles 4 and 6. Once they've had 6 cycles of chemotherapy, the standard of care is to give them maintenance immune therapy called avelumab. In this trial, half the patients will receive 6 cycles of chemo, followed by maintenance immune therapy, which is the standard of care, and half of the patients will receive a shorter course of chemotherapy, so 3 cycles, and go on to the maintenance immune therapy earlier. The primary endpoint for this trial is quality of life, and we predict that patients will have a better time in terms of quality of life if they receive a shorter course of immune therapy. We've opened this trial at many sites in the UK and in Spain, and we expect to get 240 patients. We'll be opening in France in the middle of next year also. EV302 is another trial for metastatic bladder cancer or urothelial cancer, and this includes a combination of drugs, EV, which I mentioned before, which is the antibody drug conjugate. Now, antibody drug conjugates are basically chemotherapy attached to a more targeted molecule that is supposed to deliver the chemotherapy in a more targeted way to the cancer. If you think of the analogy or the tale of the Trojan horse, if you imagine that the wooden horse is the antibody drug conjugate and it can deliver the chemotherapy which is inside and cause much more damage to the cancer cells than giving chemotherapy less targeted into the vein. In this trial, the EV is combined with pembrolizumab, which is an immune therapy agent. And in this trial, we're comparing this to standard of care chemotherapy of gemcitabine and cisplatin. This is a worldwide trial, and we've actually just closed to recruitment here as they've met the recruitment target, but this is involving over 800 patients worldwide. Moving on to kidney cancer, that was a whistle-stop tour of urothelial cancer, but I spoke for 20 minutes. So moving quickly on to kidney cancer. Kidney cancer is a bit more common than bladder cancer, and survival is a little bit better, but we still have room for improvement. There are different types of kidney cancer. These are pictures of kidney cancer cells when looking under a microscope. The most common type of cancer is a clear cell kidney cancer, and less commonly we have papillary cancers. Now, most of the trials we conduct here are in clear cell cancer, and lots more work needs to be done in papillary cancer. The causes of kidney cancer are on the screen. If you are male, you're twice as likely to develop a kidney cancer than females. Smoking is a big risk factor. Obesity is a big risk factor. As for many cancers, it's due to the hormonal profile that happens when there's more adipose or fat tissues in the body. Certain medical conditions, such as high blood pressure, certain medications, there is a genetic element like there was in bladder cancer, and there are some genetic syndromes, such as VHL, which stands for von Hippel-Lindau. Chemical exposure, again, things like paint stripper, textiles, and many cases, and we see lots of patients saying, why have I got this? And we don't have an obvious known cause. The symptoms of kidney cancer are similar to those mentioned for bladder cancer: fever, fatigue, flushing, anemia because of the blood loss through the kidneys. You can get high blood pressure, legs and ankle swelling, blood in the urine, weight loss. You might have a flank pain or mass, and loss of appetite. In the textbook, the triad of symptoms for kidney cancer are blood in the urine, flank pain and an obvious mass, but we actually don't see that in that many patients, probably less than 10% of patients. The kidney cancer staging is a bit more simple. It's to do with the size of the kidney mass. So stage 1 is if it's less than 7 centimetres, stage 2 if greater or equal to 7 centimetres, and then stage 3 and 4 are to do with the amount of extension or spread. I think the kidney cancer treatments are a little bit more simple to understand. If it's non-metastatic, meaning it is confined to the kidney, then the treatment option is surgery, which is called a nephrectomy. If the cancer has spread beyond the kidney, so it's metastatic, then the treatment will be systemic therapy. These are the ESMO guidelines, which are the European guidelines. You don't need to know these. If you come to your appointment, we'll talk through these with you, but we basically grade the kidney cancer according to risk, so good, intermediate, or poor risk, and this is usually based on blood test results. You can see that demonstrated here, but the treatments are different for good versus intermediate and poor risk. This is quite a nice diagram, although I realise it's complicated, but it just highlights the important takeaway message from this slide is that all of the red boxes represent different treatment options we have for kidney cancer. And as you can see, we have lots of different targets for this cancer. And you'll see when I chat about the trials that we're doing here are mainly using combinations of these different targets to try and attack the cancer from many different angles to try and increase the efficacy of the treatments. We hope that giving some of the treatments together will be synergistic in targeting the cancer and have better outcomes for our patients. So some of the key trials in kidney cancer, we have one called MK012. This is for patients with advanced or metastatic kidney cancer who haven't had any therapy before. If you have a look at the diagram I said here, then they may be offered some immune therapy in the first-line setting, such as nivolumab and ipilimumab. And actually, more recently, the combination of lenvatinib and pembrolizumab has been improved by NICE in the UK as a standard of care. In this trial, we are comparing that standard of care of lenvatinib and pembrolizumab versus different agents. And I won't go into detail about these different agents, but they are essentially different targets on this diagram. This is quite a large trial with over 1,400 patients per worldwide. UO3B is a trial similar to MK12 in that it's using similar combinations of experimental treatments. So going back to that diagram of all the different treatment options, this is again using a different combination, but this is for patients who have received at least 2 lines of therapy. So this is for patients a little bit later in their treatment journey, and we are seeing whether these treatment combinations are safe and effective for treating kidney cancer. That is my whistle-stop tour of GU cancer and some of the interesting trials that we have here. We have many trials, over 15 going on at Barts for GU cancer, so I couldn't include them all in the presentation. But if anyone has any interest or has any family or friends that are considering being involved in a GU trial, then please do reach out to our team and we can talk about all the different trial options and whether you'd be suitable.